Now we will start the session. I am Dr. Tayyaba, Fellow of Pain Medicine and currently working as Assistant Professor at Farooq Hospital, and he is my colleague.
Good afternoon. I am Dr. Salman. I am working as a specialist in Navigare Hospital.
We are honored to moderate this session of navigating interventional pain management. And before starting proceeding for the speakers, I would like to invite our chairpersons. Our first chairperson is respected Dr. Amjad Ali. He is head of Department of Anesthesia and Pain Management, Bolan Medical College. He is a skilled and certified anesthetist and pain management specialist. He is working industriously for the development of specialty of anesthesia and pain management at Bolan Medical Complex. He is ex-instructor Agha Khan University and ex-assistant consultant King Faisal Specialist Hospital, Saudi Arabia. Sir, please, you are invited on stage. Thank you very much, sir, for your presence. Our next chairperson is Professor Dr. Liaquat Ali. He is Professor of Anesthesia and Head of Department at Gangaram Hospital. He has special interest in regional anesthesia and pain management. Sir, we are honored to have your presence over here. Now I would like to invite our first speaker of the session, Dr. Mohjir Baloch. Dr. Mohjir Baloch is a full-time pain consultant and clinical lead of the pain management as his department at NHS-based Frimley Hospital. He is regional advisor for pain medicine for Oxford Deanery at FFP MRC Examiner and secretary of the British Pain Society Intervention Special Interest Group. He is course director for the Society of Ultrasound Guided Pain Interventions workshop at Royal College of Physicians and leading pain management consultant in Surrey and Hampshire. Thank you, sir, for your presence over here. The topic he is going to present is Botox for migraine, a needle in the right direction. So please.
Assalamu alaikum wa rahmatullahi wa barakatuhu. Many thanks to the STP committee for inviting me once again to Paincon4. I can't believe it's been 9 years since the first Paincon happened, and I was invited to come along to that and experience what a wonderful organization you have here. And I've been very impressed with the quality of the way that things have been organized and by the quality of the lectures we've had so far. So, okay, without further ado, I'm going to talk about Botox for migraine. I've got 20 minutes, is that right? I'll try and stick to time as much as I can, but there's quite a lot to cover. So let's get started. Okay, so what am I going to talk about? I'm going to talk about Botox. I'm going to talk about Botox specifically in terms of its role in chronic migraine. As part of that, we're going to talk about the PREEMPT trial, which is very pertinent to what we're going to be talking about with relation to Botox and migraine. I'll present some of our data so you get an idea of what happens in the real world. And then, importantly, I'll go over some practical tips that I've collated having done this sort of procedures over many, many years. I've got nothing to declare. Some of the slides, though, have data from AbbVie, which is the company that makes botulinum A toxin, or Botox, in the UK. Right, so it's customary to show where the speakers work. So that's my hospital, Frimley Park Hospital, down in leafy Surrey, about 30 miles from London. It's a big DGH, 700 beds, and we have 6 chronic pain consultants and 3 nurses in pain, 3 psychologists, and 3 pain physiotherapists. So it's a multidisciplinary team. Okay, botulinum toxin, what is it? So it is a pathological toxin produced by the bacteria Clostridium botulinum. And actually the toxin is very similar to tetanus and anthrax. The A and B toxins, which are the ones that are used clinically, cause a flaccid paralysis. There are actually 7 types of botulinum toxin. The one we're interested in is type A, and that's marketed as Botox in the UK. Now, Botox is a bit one of those wonder drugs, and we were discussing magnesium earlier on, and the multitude of actions that magnesium has. Well, Botox has loads of different disparate actions as well, from spasticity, which we all know about, to its use in hyperhidrosis, and also, which I'm not going to touch upon on this lecture, its use in peripheral neuropathic pain. So how does it work? I'm going to talk about the basic sciences. Why? One, because I like basic sciences, and two, because to try and understand how Botox works in migraine, you've got to understand what's happening at a molecular level. So we all know you inject Botox, you get muscle paralysis. How do you get that? Well, because it blocks acetylcholine at the neuromuscular junction. But actually, that has nothing to do with the way that Botox works with migraine. So it's nothing to do with its muscle relaxation mechanism. What we're really interested in is its effects peripherally and also centrally. And I'll talk about the mechanisms of how migraine develops. But what I want you to remember, if you remember nothing else about this slide, is our friends down here, substance P and CGRP. And what Botox essentially is doing something very, very clever. These vesicles that contain the neurotransmitters within them need a specific protein to bind with the cell membrane to get released. And what Botox is doing is it cleaves this snare, it's called an SNARE protein, and that prevents the vesicle from combining with the cell membrane and hence prevents the neurotransmitter being released into the synaptic cleft. So a very clever mechanism of action. And that effect happens both in the peripheral nervous system and also, importantly, in the central nervous system. All right, so we've talked about how Botox works in general. What has this got to do with migraine? Well, migraine is both a peripheral sensitization, inflammation, irritation of the pia and dura mater through vasodilatation. And again, our friends CGRP and substance P play a very important part in the vasodilatation and that peripheral neuropathic sensitization or sensitization that we're getting, but also through first and second order and then third order transmission through the thalamus. We're also getting central effects that are resulting in the presentation that we find that patients with migraine have. So you've got two mechanisms going on, and actually Botox is working for both of them. Now, I'm not going to bore you with the ins and outs of this slide, but I just wanted to re-emphasize the point. The effect of Botox is in peripheral nerves and on central nerves, nothing at all to do with its effect in muscles on how it helps with patients that have migraine. Okay, how are we doing for time? We're doing okay. Now, how do you think that people decided to use Botox to treat migraine? People were using Botox for its effects on muscles. And the story goes that in the late 90s, plastic surgeons out in California were injecting lots of Botox, shall we say, into ladies of a certain age, who were coming to them and saying to the plastic surgeons, not only am I looking younger, but my migraine's gone away, or my migraine's got a lot better. And they thought, what on earth is going on here? So on the back of that, further research was conducted, and we come to the situation whereby, which is what I'm going to talk about now, a large multi-center trial was set up to look specifically along the lines of the role of Botox in migraine. So it actually came from the cosmetic field initially. That was where the link-up was made of its use. Now, the other thing I want to stress here is that Botox is used for a specific type of migraine in specific circumstances. I'm going to be reinforcing that over and over again. Botox is not for every type of migraine. There are many, many different types of migraine. I'm not a neurologist. I don't diagnose migraines. All of our referrals come already diagnosed from neurology, but there are many different types of migraine. Botox use is only for chronic migraine, which is a small proportion of the population, specifically defined as migraine in which patients have more than 15 or more headache days per month, and that could be any type of headache. So they all get given diaries, and they're asked to fill those diaries in, and they're listing any type of headache they get, of which more than 8 are migrainous. So i.e. they've got an aura, they felt sick, they needed to use their rescue migraine medication, and that for a period of 3 months. So if you have got more than 15 headache days per month, of which 8 are migrainous, that defines you as suffering from chronic migraine, and you may be eligible for treatment with Botox. But there is another caveat which I'll talk about later. Right, so this is the preempt trial, or 2 trials I should say, because there's actually 2 global trials, multi-center trials, big numbers involved. There's about 1,500 patients in each of the trials. And essentially, I don't know how well you can read that, maybe it's a bit blurry, but initially what happened was that they were followed up for 4 weeks before they had any form of injection. So they fulfilled the criteria, chronic migraine only. They had to be off any migraine agent that they were using before going into the trial, and they had to stop using their rescue medication. They get randomized, so some of them get botulinum toxin, and that was the protocol sites, which I'll show you later on, 31 injections, and then half get normal saline injected at the same sites. They're then followed up after 3 months at the 12-week stage, and they are offered a second round or they are given a second round of treatment, either with saline or with Botox, and then followed up again after 3 months before it enters an open label phase, where they're actually given the option of whether they wish to continue or not, or to change treatment. So there was long-term follow-up of both of those 2 groups. Again, multi-center, large numbers, double-blinded and placebo-controlled. So it was a fairly robust sort of study or group of studies. And essentially what they found was that the number of migraine days reduced by between 8 and 9 on average. And that was not a short-term effect. So the effect came on within a month, okay? And it tended to carry on for at least 3 months after a single round of injections. Of a single round of 31 injections, they're getting fairly quick onset, and they're getting prolonged effect. To compare that to saline, and this has been the criticism, I've got some colleagues who don't believe in the use of Botox for migraine, and they say, well, what about the control arm? How much reduction did they get? They got 6 reduced migraine days a month, simply by injecting normal saline. So and that's always going to be the problem with placebo. We know you're going to get at least a minimum 30% effect, but nonetheless, it reached significance, and therefore, on the basis of this trial, we now, through national guidelines, we now recommend the use of Botox within chronic migraine. And actually, I'll show you some of our data later on. That has been my experience. So usually, within a couple of weeks to 4 weeks, they start noticing an improvement, and it lasts for that 3-month stage. Sometimes it's lasts for much longer. I've had a few patients where it's lasted after a single round, it's lasted over a year. Okay, so this is my data. So I got my pain fellow to collect data for just over a year, 24 months. We had 41 patients. So that gives you the idea of numbers. We get, on average, 250 to 300 pain referrals a month. And this is over 24 months. So we're not talking big numbers here. So it's not going to open the floodgates if you start offering Botox, because it is very specific. So we did 41 patients. Unsurprisingly, the majority were female. We use a HIT and MIDAS scoring system, as well as giving them the pain diaries. That scoring systems, the HIT and the MIDAS, look at the impact and the disability of their migraine. The scores in themselves from those questionnaires do not determine whether they get the Botox. The Botox decision is purely based on their frequency. But we add that in because it gives justification for us to continue treatment, because you can really see how badly these patients are being affected. A lot of them will be having chronic migraines almost on a daily basis. So it's a debilitating condition. And of our patients that we looked at, 3/4 experienced a greater than 50% reduction in frequency. And I cannot reinforce to you how much of a difference that makes to quality of life, because these patients are significantly disabled because of their migraine. So 1 in 5 are classified as being socially disabled because they've got migraine. It costs the NHS, or not the NHS, but the, European healthcare, about £95 billion a year managing patients that have migraines. It's a big healthcare burden. They're not working, they're not paying taxes, they're not engaging in life. So it has a huge impact. So 75% experienced an improvement. And that is what we find generally, that a lot of people do respond to this. And 3 that didn't, out of the 41, 3 it didn't work in, they went on to have greater occipital nerve blocks and the CGRP antagonists, which I'm not going to talk about. That would be a different can of worms. But they go on to, if they fail Botox, then they go on to have a greater occipital nerve block or rimegepant. And we didn't get any significant adverse effects. Typically patients, and I'll show you the effects, typically patients that had come to us, myalgias maybe, a bit of a head drop, a bit of drooping of the eyelids, but all temporary. None of them said, we won't come back. So nothing significant in that. Before I come to this, I just want to reiterate something, and that is that we've talked about chronic migraine as being the indication for giving Botox, 15 headache days or more, of which 8 must be migrainous. The other caveat is that they must have tried 3 anti-migrainous drugs. So they must have tried something like topiramate or candesartan or a beta blocker and failed before they have Botox. So you've got to have chronic migraine plus failed treatment with 3 other anti-migrainous drugs before they go onto this. And as I said before, all of the referrals are coming through neurology. So the neurologists have made the diagnosis, they've tried them on anti-migrainous drugs, they haven't worked, then they come to my clinic for consideration of this. Now, what are the injection sites? We've got 31 injection sites, all in all, and they are predominantly around the face. Go back. Around the face, front of the face, and these are actually, from practical point of view, the most painful ones, and they bleed the most. So just be warned when you do the ones around the face, those are the most painful ones. So you have to constantly talk, and we were talking earlier about patient advocacy and building a rapport with patients and how important that is. That's very important in these patients because they've got a crushing headache and you're about to jab them 31 times with a needle. You've got to set their expectations. You've got to keep on talking to them and encouraging them and reassuring them when you're doing these injections, because it is a lot of injections. And I'll show you the equipment that I use. So we've got 3 along the corrugator. We've got 1 in procerus. Frontalis, we've got 4, and then we've got 4 along temporalis muscle. The sites are fairly important, and the reason is because they run close to where the nerve supply is running. And remember, it's the nerve supply which is where the effect is going to be happening by uptake through the muscles. And then we've got injection sites around the back. Most of them are within the hairline, and then we've also got 3 that goes on each side of the trapezius muscle. And what we tend to do with our patients is we get them to frown or crunch their eyelids up just to be able to feel the muscles more easily. So that's a sort of a top tip for you. So we've already said chronic migraine, those that have failed 3 prophylactics. Now these are some practical tips. The Botox has to be stored at 4 degrees. You can't leave it out, otherwise it'll go off. So that's very, very important. It's kept in the fridge. I get the nurse to bring it to me when or just about before I want to reconstitute it. So it's reconstituted. We use a 200 unit vial of Botox. I don't know what vials you get here in Pakistan, but I make a 200 vial up with 4 mils of normal saline. I divide it up into 4 1 mil syringes, and we're using the tiny, the needles they use for insulin injections, the 30 gauge needles. Those are the ones we're using, the smallest needle you can get. And we have a special hazard box. You can't throw the needles into an ordinary box. You have to use a special hazards box. We're only injecting 0.1 of a mil at each injection site. So it's a small injection. It does sting as it goes in, and it can be a bit uncomfortable, but most patients, I've never had a single patient who said, stop, don't continue. So though it's uncomfortable, you tell them that in advance, most of them are happy for you to continue doing it. We've already said that they bleed, and especially the ones around the front. If they do bleed, you can't dab them. You can't press the Botox because it becomes denatured. You have to just lightly blot it. And the most important thing, keep patients reassured. Well, we talked about this as well. I mean, that's the wonderful thing about these discourses. We talk about many issues, and one of the things we talked about is consent. So we get written consent for this. We talk about the risks, typically myalgia, muscle pains, are flu-like symptoms that they get for maybe a few days. Ptosis is common, head droop is common. It's temporary, it will go away. Just reassure them that these are temporary things. As I said, we find that the effect of the Botox comes in within a couple of weeks. So it's pretty quick onset. We offer them 2 cycles of Botox before we say no more. So after the first cycle, they might not respond. We offer them a second cycle. Because as per preempt, they gave them 2 cycles of Botox. So we offer them 1 injection. We bring them back 3 months later. We offer them a second injection. If after the second injection they have no improvement, then we discontinue, and then they go down the greater occipital or the CGRP antagonist route. If their headaches become episodic, so if the headaches, they get less than 8 headaches a month, they become episodic, therefore we stop and pause. And hence the patients that I've had, some patients that have gone a year without needing Botox because their headaches gone from chronic to episodic. So you can pause it for a while if that happens. They all keep a headache diary with the scores. And actually, again, we're talking about multidisciplinary use and training people up. Most of the Botox in my clinic is done by the nurses. I only get involved in the more complicated patients. The vast majority, including follow-up and the injecting, is all done by our pain nurses. And they run specific Botox clinics for that purpose. Right, so in summary, Botox is safe and effective in those patients that have got resistant chronic migraine, and we've defined what that is already. It provides long-term benefit, 3 months at least, and in some cases, much, much longer. But it does require specifically careful handling and application and injection, and you have to be very, I would say, communicative with your patients, both before and during and after, to make sure they're reassured and that they don't get worried or put off by having further treatment. Right. That is it. Any questions? Are we taking questions at the end? At the end, fine. Great.
Thank you so much, sir. It was a quite informative session. Now we will proceed towards our next speaker. Our next speaker is Dr. Agha Sajjad. He is graduated with honors from Sindh Medical University. He then went to USA for clinical training in anesthesia and pain management. After passing his anesthesiology and pain management boards, he started working as director pain clinic at Lewis, Delaware. Due to his outstanding achievements in pain relief, especially his work on spinal cord stimulation, he was awarded as top pain specialist in the state of Delaware for 3 consecutive years. Thank you, sir, for your presence over here. Please.
If you'd not had a complication after pain management interventions, you have not done enough procedures. Professor Javed Alam Khan, 15 years ago or 20 years ago, a professor of ophthalmology who founded Abbasi Shaheed Hospital in Karachi, went for cervical epidural steroidal injection. While he was sitting in the car, he collapsed. They rushed back him to the emergency room. The doctor who did the procedure had already gone, and he died. He was my friend's father, and their whole life has been changed. There's another case right in this country, not outside the hospital, right inside the operating room. A patient was given lumbar epidural steroidal injection, and patient died. The list is huge, it's long. There are minor complications, there are major complications, and most of them are not reported. Almost none of them are reported in Pakistan. Now this is Dr. Syed Mubin Akhtar. He had a cervical epidural steroidal injection for cervical radiculopathy. In the post-anesthesia care unit, after 15-20 minutes, he complained of numbness in his arms and legs. He was taken to the operating room with the airway ready to go. Of course, he was NPO, and he was monitored. He was given a little bit of midazolam. He recovered, went home. After a week, he reported 50% relief of his neck pain. After 3-4 weeks, he came back, and he had another cervical epidural, and he didn't have cervical radicular pain for 15 years. There was a very top guy, a very high position guy in Sindh Police, and came for celiac plexus block in the CT scan. He was NPO for 8 hours. For celiac plexus, we just go beyond our limits. And he was position prone for celiac plexus block in the CT suite. He was given 2 or 3 milligrams of midazolam for mild sedation. The patient started vomiting. He was moved supine. He was intubated right then, transferred to ICU, later found out that he had intestinal obstruction. He had surgery. He recovered fully. And the anesthesiologist and the pain specialist who did the first block was literally forced to do block on him again. The pain specialist was hesitant. I was like, you can go to another center. And they said, no, we trust you because the whole hospital and the critical care doctor said that he was managed effectively with the complication right in the CT scan. So the complication could be a difference between life and death. The only complication, the only pneumothorax in my whole career I got was not from 8-inch long needle for celiac plexus block or some kind of shoulder injection. It was an upper lumbar trigger point injection. Obviously, the patient had very minute. She had to be hospitalized for 2-3 days, no chest tube, nothing. But nothing, even the simplest trigger point injection can have a complication. So what was the difference that was found out between the people who died and the people who had complications and who survived? The one main difference was that they were done, the patients who survived were done by a board certified, an FCPS or somebody, an anesthesiologist or a double board certified pain specialist and anesthesiologist. Also, all these patients, I went to a free pain camp, and then there was it was organized by non-anesthesiology, non-pain specialists, other physicians. And I was there just to see patients, and I was insisted to do a shoulder block for a patient with frozen shoulder. So, in those days, I had just came from States, so I was expecting everything would be like, what the protocol is formed. I went to do the block. I just injected the local anesthetic on a 67-year-old lady, and she started feeling dizzy. And it was like 2-3 milligrams. So I was like, what's her history? What's her blood pressure? And nothing was done. And I was like, put the patient down, put the legs up, get me the blood pressure, let's check her. Well, there was no blood pressure apparatus in that area. And from that day onwards, I decided I'm not doing any procedures in the free pain camp. If I schedule them, I schedule them next day in the operating suite or where all the emergency and resuscitative things are available. But it's just not treating the complication afterwards. Treating the complication, doing the right thing, starts from the very beginning. It starts from diagnosis, where the pain is coming from. Every back pain does not need an epidural steroid injection. We all know that. We should be always very familiar with the management of side effects of medications and the complications of interventions. And everybody should be prepared about that. This is the history used in our clinic, an extensive history. Again, like all my colleagues said, that one person cannot take 45-minute history from a patient. So they are trained professional nurses who take a detailed history so the time is saved. There are also counselors, because here in Pakistan, people would like to ask their medications, their other things, few times. So one time a doctor can explain, and those counselors develop a rapport with those patients, and they explain them 3-4 times. And if you see that the current medications are here, but then there's a separate question, are you on any blood thinners? Not to miss the blood thinners, the clopidogrel, the stuff which prevents you to do many procedures. So even tiny, tiny things are taken into account. The emergency medicines. People doing every 2 years ACLS or every year ACLS, they think, well, we can do a lot of things. If you wake up an anesthesiologist 2 in the morning and ask them, what's the dose of phenylephrine? It will be 50 to 100 micrograms per, at the time if the blood pressure is low. Or 0.5 to 1 milligram of adrenaline for certain cases. So not only, they should be in your genes, those doses for emergency medicines. What is the toxic dose of local anesthetic, lidocaine, bupivacaine? The non-anesthesiologists usually don't know. They don't know if you have a seizures, what to do. So it has to be, in America, the oral surgeons who have 7-year training, they have 6 months of assigned training in anesthesia because they have to use nitrous and other agents. And they get patients, they have to do their airway and pre-op assessment. They get patients for 6 months, only then they can use nitrous and other stuff. So it's not like, I've done ACLS for every year and, I'm good to go. It's just not one complication. It's life and death. Also, the person should be very familiar with the fluoroscopic or ultrasound techniques and what to look for. It's just not like, doing a weekend course and you're on the top of stuff. It's practice, practice, practice. The, vertebral artery is not very far from cervical, procedures. All procedures, even, in our clinic where we do small procedures like, elbow injection, tennis elbow injection or something like this, we have everything available. Even if the patient goes, into some other complication, it has to be available. And in Pakistan, we lack this a lot. Our emergency medications, they do get expired every 3-4 years. We replace them. But, if in 10,000 patients, if you save one person's life, it's worth it. And these are very cheap medicines. And, the airways are checked. You have access to oxygen, suction, ambu-bag, all that stuff that has to be there. So the specialty of pain management, it's not just needles. We have emphasized here, but in Pakistan, quackery has started everywhere. people just ask me, hame injection sikha do, just teach me an injection. Well, do you know the toxic dose of xylocaine if you are accidentally, inadvertently, you inject it in a vein or something? They don't. And how are you going to, manage that? So it has to be done by qualified. You have to get everything available. I just didn't want it to go long. The abstract has things available. But my emphasis was that if you want to do even Botox injection or every injection, be prepared for complication because one day you will get it. Thank you.
Thank you very much, sir. It was a very good session. Our next speaker is Professor Dr. Syed Mehmood Ali. He is working as Associate Professor and Head of Department of Anesthesia, Critical Care and Pain Medicine. He is an interventional pain physician who established pain department and recognized that department for second fellowship in pain medicine. He is gold medalist in pediatrics and is a part of faculty of anesthesia at CPSP as well as level 3 and 4 supervisor of anesthesia. He is Vice President of STSP Society. Sir, please welcome on stage.
Thank you so much. Thank you so much, Dr. Taiba. And thank you so much, Dr. Agha Sajjad Sahab. आपकी वजह से मैं उठ गया. I was sleeping, and because of your presentation, two things happened to me. One thing, I was alert. Second, at one stage I thought I should quit pain medicine. It's so horrible and so complicated. So I think the positive aspect is always there, and it's do happen. Definitely, I do agree with you. If you work, this thing will happen, and we should be prepared for these things. Everybody is asking for the short track. They want to go just, and I think there is other aspects as well. So everybody wants to do things. Here, coming back to my topic, big joint denervation, and about this topic, and whenever this topic was given, I was talking about my orthopedic surgeon. They always say कि हमारी जो रोजी रोटी है ना वो shoulder, back, and knee. They say 80% of our practice is back pain, shoulder pain, and the knee pain, and you are involved in these things. So it's always a conflict, and sometimes, most of the time, we have this chit chat with them. Chronic pain management of big joint pains such as shoulder, knee, sacroiliac joint, hip joint require interdisciplinary, integrated approach. ये अभी भी आगा साहब ने भी यही बात की. It's not about I always say pain medicine is a package. It's not about the thing that just you do the intervention and you will get the results. So it's a continuous process. You have to go for the physio, you have to go for the rehab, you have to go for the medications. Radiofrequency denervation is a novel, minimum invasive treatment that can block pain causing nerve, provide safe and effective pain relief. Role of RFA in clinical practice for making controlled therapeutic lesion in nervous system was introduced in early 1950. And Williams wrote first paper in 1953 which showed the high use of frequency current for lesion production has decisive advantages. If we talk about denervation, usually in journal, we talk about the chemicals and radiofrequency chemicals. We can, like our low socioeconomic status, we are frequently using chemicals like alcohol, phenol, glycerol, and few setups, they are using radiofrequency, and sometimes we use it thermal conventional, sometimes you use pulse RFA, it's a cold RFA. So things are going on, and we have talk about myself, different results. It's not up to the mark like 80 to 90%. You are getting about the 50 to 60% of the result, and that is long for few months, like it may be up to a year. Individuals who have undergone successful nerve blocks, radiofrequency ablation has demonstrated a success rate of 70 to 80%. If necessary, the procedure can be repeated. I think if you follow the protocol, initially you have to give a diagnostic block, either you are getting a result or not. And like in our setup, if I ask to a patient that first of all, I will give you a block, I will see the result, if I'm getting the result, and then I will do the radiofrequency ablation. Lekin if we talk about the practically, patient says it's going to be very difficult. How I can pay twice? It's not about the insurance. I have to give this amount and then we come back again, and again I have to pay It's a bit different. A study conducted considered 42 patients. 45% of the patients reported at least 50% pain relief for long-term follow-up. Latest evidence-based application of radiofrequency neurotomy provide best practical guidelines from the American Society of Pain and Neurosciences, and as per these guidelines. If we're talking about the radiofrequency ablation, you have conventional RFA, cooled RFA, pulsed RFA, and now people are also using a bipolar RFA. And this is about the pulse RFA. We are using the pulse RFA because where the motor functions, mixed nerves are there, definitely we have to spare the things. And this is the most important thing which we have to see. We should not harm the patient. If it's a motor, there's more concern about the movement, and like big joint, shoulder joint, or the hip joint, or the knee joint, it's a part of the motor system. For ideally, patient must have a positive response to the nerve block procedure to qualify for RFA, as a positive response to lignocaine nerve block correlate with the favorable response to nerve ablation. If we talk about the shoulder joint, and we have seen osteoarthritis, bilateral, severe pain, and I have encountered a patient with hepatocellular carcinoma with mets in the head of the humerus with terrible pain. He's not complaining of pain in the abdomen or somewhere else, but to the shoulder. And I tried RFA, but it doesn't work. It's not got a good result. Then I did the pulse RFA of the suprascapular nerve, and initially he was in pain, but after 2 to 3 weeks, he says that he's feeling a little bit better. But he's not up to the mark. If we talk about the shoulder joint, glenohumeral joint, sensory articular nerves, 3 sensory articular branches are suprascapular nerve, axillary nerve, and the pectoral nerve. Technique, we are using both techniques, ultrasound and fluoro. Initially, I started with the fluoro, but with the passage of time, my practice is shifting more toward the ultrasound, because it's a real time, and you have having it for the nerve, especially you are getting a good results, especially when you view the Doppler and you see the arteries, and usually nerves are close to that. Denervation can be with the chemical, RFA, neurotechnique, cryoneurolysis. And if you talk about the suprascapular nerve and axillary nerve, the first, I will talk about little about this because we have short of time. The patient is in prone position with allow access to both the suprascapular and axillary nerve branches. The hand is usually pronated. Position you can change according to the comfort of the patient. Here you can see we have to coagulate at the 5 portion, like the number 1 is. This is suprascapular nerve, is the articular branches, then the axillary nerve is articular branches, and the lateral pectoral nerve. So we have to coagulate at this level for usually suprascapular nerve, and then to the axillary and the pectoral nerve. Here this is the anatomical and by the pectoral presentation. Lateral pectoral nerve, for the lateral pectoral nerve, patient should be supine, and usually coracoid process is the target area where you find the lateral pectoral nerve, and you can easily do it. And if you use the ultrasound, it's a much easier and very effective, good results here. This is what I am talking about. These are studies are there where you can compare it with the pulse RFA of the suprascapular nerve. Suprascapular nerve with the suprascapular notch, and it's usually the sensory supply of the shoulder, mostly on the posterior side, not to the anterior. But we have seen, practically I have seen a very good result of this pulse RFA, although sometime with conventional RFA is my always a preference, but with the motor sparing, I have to go for this pulse RFA. The result are a little bit late, but you have a good result. Now hip joint, basically 2 nerves. If we talk about, this is a femoral and obturator nerve, and we have seen these patients with severe osteoarthritis, and they are not willing to go for the surgeries. Movement is limited, and again, ultrasound guided fluoro, started with the fluoro, but ultrasound guided really is a very good, and you can easily do it. Technique again, you can use chemicals and thermals. Usually RFA is a very good option, but in some patients or of the availability, we have these some cases of chemical neurolysis with the phenol, that is obturator and femoral, but we also did some cases like Pang block with phenol, about 6% phenol in the Pang block, and usually a very good result. I was not expecting that, but we give a diagnostic block and later it works very well. We will show you again patient in the supine position, fluoroscopist position with the AP view, and from needle is from the femoral. You come from the lateral to medial side, and from obturator you will come from medial to the lateral side. Where is the branches? This is obturator articular branches, and this is the femoral branches, and this is a in lower portion we can see the RFA. Okay, this is for the obturator and this is for the femoral. This is what I was saying, and we some studies also there. The ultrasound guided pericapsular nerve group hip joint phenolneuralgenesis of palliative pain, and it's really work very well. And another patient like we are going for that, the IPAC block for the knee joint, and we are on the follow-up of these patients. So as you all know, this is the direction of the needle, anterior spheric iliac spine, iliopubic eminence, and the pubic ramus. This is a nerve, femoral artery, and femoral vein. So this is a very good and safe block. You can go for that, and you're having a very good result. If you don't have a RFA, it's not necessary. I always say it's not necessary. When we talk about the pain physician, new coming pain physician, they always say we don't have RFA. We don't have RFA. I always say pain medicine is not dependent on RFA only. There's a lot of other ways as well. You can go with a simple block as well. You can give a local with steroid or simple PRP like Botox. Like there's a lot of ways. It's not dependent on the RFA, and they say we don't have RFA machine, so we can't do it. I think this is not the way like that. You have to start it. You can start it with the basics things. Knee joint innervation, like genital neurotomy, usually have multiple articular branches, but in conventional way, they are superior medial articular branch, superior lateral branch, and inferior medial genicular nerve. Place the patient in the supine position with knee about 20 to 30 degree flex. Fluoroscopy is used to identify 3 sites where the condyle and the shaft is the junction, and usually where you find some articular branches, genicular artery and nerve. Again, you can do it under with fluoroscope and the ultrasound as well. Again, we are switching to the ultrasound where you can easily see the genicular artery and the nerve where you can infiltrate. You can use phenol, alcohol, or you can give a simple block, and you can do ultrasound guide RFA of these procedures. You get a good result. The target inframedial genicular nerve needle inserted at the junction of proximal tibial shaft and medial tibial condyle. Here you can see on the supromedial, supralateral, and inframedial part of the thing. And usually it should be on the lateral view, the depth is around the middle or anterior two-third and posterior two-third junction. These stimulations, usually it works. It can come when the sensitive stimulation is given. It may be on the middle of the shaft, or it may come early because it's not a fixed area. Its variation is always there. Ideally, the nerve target in each quadrant are accessed with one skin entry point to minimize patient trauma and discomfort. More study needed to compare the effectiveness of classic 3 nerve approach with a more comprehensive. Here we have an ultrasound guided supralateral genicular artery, supromedial genicular artery, infralateral genicular artery. These are the small articular branches. Here you can infiltrate because usually most of the time, I will talk about myself, most of the time I did not find the genicular nerve, so I have to infiltrate. In some bookish pictures, books and videos I have seen, but it's very difficult to visualize the genicular nerve. Ultrasound guided genicular nerve block versus alcohol neurolysis for the treatment of advanced knee osteoarthritis patients. So you can go for that, a very, I think, effective and cheap way. You are getting a very remarkable result. Risk factor associated with RFA, failure, it happened. It's the way we are talking about. If you do the procedure, these things happen. And most of the time, my pain medicine, when you talk about the patient, he always says, what is the complication? So most of the time, my case is usually a safe under control environment. The best thing, the thing is that most of the time, maybe sometime you get the result. The good thing is that we can repeat it. You can do it again. Lesion size, if small lesion can miss target nerve and decrease the number of extent of nerve captured. Mixed nerve target are to be avoided, as if these are affected, then undesirable motor sequence can occur. Increased chances of neuritis and skin burn. That's why we, at the end, when the lesion is given, usually you give a liquid and steroid to avoid the neuritis. If it, I have 2 minutes. Tips and tricks for the improvement. Improvement can be made by effectively reduce and managing risk. Use of diagnostic blocks before selecting appropriate patient. So patient selection is very important. I go usually like genicular neurotomy, if you talk about the genicular neurotomy. Sometimes I have patient, I go ask them, I think it's better for you to go for the knee replacement. This is, most of the patients, when they came to me, they said, Doctor Sahab, we already discussed with these things with the orthopedics. We don't want to do the replacement. But still I say, and I usually document. Okay, you discuss the patient with about TKR, but patient refused or reluctant due to his financial issues or health issues. So we are going for the next step. Molecular needle technique use कर सकते हैं. Large lesions are desirable to risk of missing target. But you are using a large diameter, it's causes pain as well. It's more pain, it's very difficult to, but you get a good chunk of the lesion and you have a good result. Some school of thought suggests that neuritis can be prevented by use of steroid after lesion. However, difference exists among the practitioners. Burn chances can be reduced by using conventional site of dispersed electrode in monopolar frequency. Avoid placing ground plate on scar. For precautions and tip for the first day, like RFA, you give the icing, and after 2-3 days, you can give the warm to reduce the muscle spasm, and you have got a good result. Thank you so much. Thank you.
Thank you so much, sir. Next up, I would like to invite Dr. Alan Blake. Dr. Alan Blake is a fellow of anesthesiology and the Faculty of Pain Medicine. He is working as a consultant in pain medicine and anesthesiology in Tallaght University Hospital, Dublin, Ireland. Dr. Allen is also a supervisor of training for pain medicine in Tallaght University Hospital and a board member of pain faculty with an interest in the curriculum and training. Sir, please.
Good afternoon, everyone, and thank you very much for the warm welcome to Pakistan and your lovely city, Lahore. I've had great hospitality here, and congratulations to the organisers for such a fantastically run conference. The session is called Interventional, Navigating Interventional Pain Practice, and I'd just like to give basically what amounts to a narrative review of my experience having been appointed as a consultant to a tertiary level public hospital in Ireland within the last 3 years. So I have no declarations of interest. So I'll just give you a snapshot of Ireland for anybody who's not familiar with the country. I liked Brigadier Asif's analogy earlier where he said we're like fish swimming upstream in order to develop our practice. And it's a good analogy because we are swimming in a river, and the river is the strategic environment in which we operate. So although we're individual practitioners, there's a social, political, financial and managerial aspect to being a consultant pain physician. It's something that's not perhaps well taught when you're a trainee, but when you become a consultant, you realize that there's much more than just being a good practitioner of individual interventions. You have to advocate for your service within the milieu of political and financial circumstances that you find yourself. You are also rely on interventional research to guide our interventional practice. So you have to be cognizant of what's coming down the line and what's pertinent to developing your service. And then I'll just give you a summary of, in brief, it's a number of small interventions that we undertook in order to streamline our service. They're not all applicable to every service, but I hope the general principle applies in that you should look at every aspect of your service when you're developing it. And then we'll summarize. So this is my institution. This is Tallaght Hospital. We're a 600-bed unit. We're just on the southwestern outskirts of Dublin in Ireland. And beyond us is mountains and fields, and to our east and north is the city of Dublin. The greater Dublin area has a population of about 1 million people. So this is the island of Ireland, and during the day it looks like this, and at night it looks like this. And I often like looking at night pictures of cities because it gives some indication of where the population and economic activity lies. And in Ireland in particular, Dublin is on the east coast here. And if you drew a line from Belfast down to the south of Dublin, you would find 80% of the population of Ireland. And almost all the economic activity of the country is within this area. And that has led people who come from Dublin, of which I am one, is to regard the rest of the country as non-existent practically. So it's Dublin and then it's whatever. So in terms of population, we have 5.2 million at the moment, and for first time in our history we have a large net inward migration. That has historically been the opposite. Irish people have always left Ireland, but now we find ourselves in the opposite position. And of note, since the early 2000s we've grown by significantly, over almost 25%, so rapid population growth. Additionally, our population is very young. We're the youngest in the European Union, and 34% of our population is below 35 years of age. We're about equivalent to a country such as Sweden and Scotland, so we should compare ourselves to those. So what does the position of our publicly funded services look like? Well, my colleague, Dr. Purcell, who's now a consultant in the south of Ireland in Cork, he did a very good study in Tallaght Hospital, the institution I work at. And in quick brief summary, there's 16 public pain services on the island. 5 of them are in Dublin, and there's 27 pain consultants for the population, which is about 16 whole-time equivalents, because all our publicly funded jobs have a anesthesia and or critical care commitment, such as my job. It breaks down to about half a specialist per 100,000 of the population. So how does that compare to our relevant neighbours in terms of international jurisdictions? Well, Oceania, Australia and New Zealand are the best at 1.3, and we're significantly worse off than Scotland, Northern Ireland, and just slightly worse than England. I looked up some data on Pakistan. I found this very good article from 2023 by Usama Ahmed and Gahir Afshan, just to see how Pakistan compares. And they noted that you have 72 pain consultants, which is 0.03 per 100,000. So you're 15 times worse than Ireland and 37 times worse than Australia and New Zealand. So you know, if I'm complaining about Ireland, I shouldn't really be complaining. You guys have a lot more work than we do. So this is the 4 Yorkshiremen. It's a famous comedy sketch where there's 4 obviously affluent gentlemen are sitting around drinking expensive wine, and they're reminiscing about the bad old days, about trying to compare how bad each had their childhood. So hopefully at Paincon4 in 30 years' time, we'll be sitting around, all of us, comparing how bad we had it back in 30 years ago. But hopefully our services will have improved by then. In terms of the political environment, we're undergoing significant health care reform at the moment. The government has a very ambitious plan to separate public and private practice at the moment. We have a dual public-private healthcare system. Healthcare is free at point of access for all citizens, all residents, but the downside of that is that there are huge waiting lists, and half the population takes out private health insurance to avoid this. Waiting lists are a political priority at the moment, and the government has allocated extra funding for this. So this is relevant for me, just coming into a service, that if there's money available to reduce waiting lists, I would like to advocate for my patients to get access to some of it. In terms of finances, in April of this year, the government forecast a record 8.6 billion surplus, which is a record budget. By September, they actually found that it was 25 billion. So we've just published our giveaway budget at the moment with extra allocation for healthcare. And the government wants waiting lists for planned procedures to be under 12 weeks. At the moment, for first procedures, we just barely scrape this, but for second and subsequent procedures, we're almost a year. And we would be one of the better public health pain services in that regard. Some public services, you could be waiting 1 to 2 years to get your procedure. In addition, the government model doesn't take into account that pain medicine and interventional pain procedures are not or rarely curative, and that it's a chronic disease model. Their model is set up for knee joint replacements, hip replacements, where there's one procedure, you get it done within 3 months, and that's it. We have patients come back regularly for interventions, as you know. So we have unique geographical inequalities. We're understaffed by international standards. We have periods of significant health reform at the moment with extremely ambitious waiting list targets, and we have financial resources to address this. So what does the interventional research look like coming down the line? Well, as Dr. Mary showed in her lecture, back and neck pain in terms of dailies or disability life years, it's either number 1, 2, or 3, depending on which country you live in. This is Ireland. It's the number 1 cause of dailies. But if you look at publicly funded health research from the National Institutes of Health, which is the largest federal, actually it's the largest public health research funder in the world, their number 1, 2, and 3 are infectious disease, cancer, and rare diseases, which affect, although it's valuable, they affect a significantly smaller subset of the population. And where does interventional pain medicine and pain medicine in general fit into this? We're essentially a rounding error in terms of the finance that we receive from public funding. Interventional pain medicine doesn't even class as a category on its own. There is no such thing as a category that encapsulates that. So we're not a significant source of funding, and that means that most of our interventional published research is either funded by industry, or it's funded by the researchers themselves. So we don't really have large-scale comparative and outcome studies to guide a lot of our decisions in terms of patient selection, timing of procedures, outcome measures to use. I know Preempt is probably one of the exceptions where we have rigorous RCTs. But for most of our stuff, we have to acknowledge that we are operating with a degree of uncertainty. So how would this feed into structuring your pain service? So our pain service in the public service looks like this. Our referrals come in from all sources, primarily from general practice, but also from other specialists. And the principle is treatment in turn. So it's an undifferentiated waiting list where, depending on the date that's on that referral, no matter how urgent your pain problem is, you go to the back of a queue. To get into our pain clinic at the moment, you would be waiting, it's approximately 25 months. So obviously that's not an ideal situation to have, but we're very much at the mercy of what referrals come in. And then say you come in to see me for your clinic appointment, and I might decide you need an intervention or you're suitable for an intervention. I'll list you for an intervention, and then you'll be waiting probably 3 months for your first procedure. And then you might go back to the pain clinic for follow-up, and then you might go for another injection, you might go for another injection, and you end up in this kind of circle of injections and clinics that's not really planned, and it might be a bit haphazard for both the physicians and the doctor. And you can start to feel a bit like Sisyphus trying to push the rock up the hill forevermore. So there was 5 principles that I just thought about when I was taking over the job in terms of what I would like the service to look like. So I'd like to be able to identify early those patients who would do the best from a pain intervention. I'd like to protect and develop the capacity within my institution to perform interventional procedures. I want to be able to offer a broad range of evidence-based interventions, and the evidence base is key. I want to be able to move those patients along the interventional pathway, but critically move them off the interventional pathway when it's clear that the outcomes are not enough to justify the procedures. And that's something that can be quite difficult to have that conversation with patients. But if you don't do that, you will clog up your interventional list, and then patients who will benefit will suffer delays in getting into that pathway. So in terms of identifying early those patients, so we did a few things. One is we did a pilot study, again, by Dr. Purcell, within Tallaght Hospital. He took 100 patients and applied advanced clinical prioritization principles to the waiting list. So instead of just having an undifferentiated waiting list for treatment in turn, you would actively manage your waiting list. You go through individually each referral and triage them into possible intervention, possible multidisciplinary, possible psychological approach, etc. So he did an audit there, and 30% of patients went for interventions. Some were referred back to the GP because they didn't need tertiary level pain clinic review. Some were purely medication management. And we then took that model and got funding under the waiting list initiative. And we've now run 400 patients through a telephone clinic where we pre-select patients who we feel might benefit from an intervention. Rather than waiting 2 years to get into clinic, we will pull them out of the waiting list and list them directly for intervention after a phone call clinic appointment. And we'll examine them on the day to confirm that the procedure is the correct procedure. So instead of being at the mercy of referrals coming in, we tend to opt for an active management process. The other referrals, not alone from the general practice, they come from your consultant colleagues. So very early within taking over the job, I had meetings with palliative care because I didn't want palliative care patients to get stuck in that 24-month loop. So they're direct referrals, direct to me. If there's a possible intervention that palliative care consultants feel must be done, they'll come straight to me. We also had a direct referral pathway, which we introduced from orthopedics, which I can talk about after if anyone's interested. So in terms of protecting and developing our interventional capacity, so one of the problems in a public hospital with public theatres, we have 14 theatres, but we're competing with all the other services for access. And at times it can be difficult to get access, particularly to radiographers. Now, before I started in 2021, they built a new surgery centre off-site. So it's just across the road from the hospital. It's 4 theatres. And we do the majority of our fluoroscopy procedures in there. And that's been a game changer in terms of prioritising our access to these theatres. So if you can have your own dedicated access, it can be helpful. In addition, I got funding from the waiting list initiative, and we rent space in this private clinic. Again, it's across the road from the hospital, and we bring our public patients to the private clinic and we inject them every week there. So this gives us extra interventional capacity. Again, because there is such a political priority on waiting lists. I'm not sure how sustainable this is long term, but we've been doing it now for 3 years, and we'll keep on as long as we can. The other thing we did was an efficiency review. Because the Reeves Day Surgery Centre is a new flagship day surgery hospital, management were keen to get good efficiency figures. Now, if you engage with management have a totally different view to efficiency than what we do. So as practitioners, our view of efficiency is no downtime between cases and perhaps maximizing the number of cases you can get done during the day. But management have different measures. Some of them are quite crude, such as theatre start time and theatre utilization, which is the amount of time, or percentage of time, that there is a patient on the table, essentially. Now, if you look at pain practitioners, using those crude measures, we're actually very inefficient because we do 16 cases in a day, say, and because we have such high turnover, there's necessarily a large amount of downtime where there's not a patient on the table. So we had to have a good meeting with management to get both our points across, and we undertook a review and streamlined some of the consenting processes, some of the check-in processes. We got a buy-in from the anesthetic nurses, and the net result to us is an extra 2 cases a day. So we went from 14 cases to 16 cases on our days list in Reeves. So we were happy with that. And again, our waiting list and theatre list. And we tried to keep control of both. So we're the only service in our hospital that controls our own waiting list, our theatre booking list. We decide which patients to book and when. A lot of the surgical services, or actually all of them, they're not managed directly by them, so they show up for a list, but they don't have control of it. So if you can keep control of your list, it's often better. And the other thing to bear in mind is that there's a difference between efficiency and productivity. So you can be extremely efficient but not very productive, and vice versa. It's good to keep an eye on both of these things rather than just relying on crude efficiency measures, which often don't reflect perhaps your case complexity or the fact that you're doing a difficult complex stimulator that might take 3 hours. You're extremely productive, but you look like you're inefficient. Okay, and the other thing was to be able to offer a broad range of evidence-based interventions. So our experience was it's a 2-consultant practice. The one consultant did neuromodulation and he was resigning or retiring from public service, so I was taking over his job, not having had as extensive experience. So we are very, very vulnerable to losing a key practitioner, and all those skills, that 10, 20 years of experience, just leaves the organization overnight. So obviously this would be a terrible blow to Tallaght Hospital and the public servants, the public patients that we had. So we arranged a proctorship and we got him an honorary contract so he can come back during stimulation cases to ongoing keep an eye on it. So that was a great help for me taking over a neuromodulation service, where if I have a difficult cervical stim or a difficult revision, I can ask my colleague to come back with his honorary contract. He can come in and help me, and he's been very, very obliging with that. So the team that we work with, or the excellence of the service, the interventional service we deliver, it's not due to having a single excellent practitioner. It's more related to your team, your structure, your leadership, rather than having one person. Because you can have one excellent practitioner, but if they retire or resign, your service falls apart. So in terms of minimum volumes of practice, so I was involved in the curriculum for our new fellowship program, and we looked at minimum volumes of practice. So there's 54 separate procedures that are required for year 1 and year 2 fellowship, and we do them all except for intrathecal pumps in my institution. Okay, so the other thing to think about is to have some steroid sparing options such as PRP or PENS. Look at your patients on anticoagulation. What's your policy around this? Have trauma pathway where you can be called to do regional, and consider your neuromodulation options. This is just an audit by Dr. Ali Asil. We looked at anticoagulation. It was causing some disruption for our planned procedures where we had patients on anticoagulation. We were waiting on letters from cardiology to guide us on bridging. So actually, when we looked at the evidence, there are some procedures that we can do on anticoagulation, and we've started doing lumbar procedures, a range of procedures on full anticoagulation. We haven't had any issues. The other thing is to move the patients along the interventional pathway. So try and move them up to rhizotomy after your diagnostic blocks, or move them on to implantation for their stimulator. Don't keep them in that eternal loop that I showed earlier. And that's just another project that we did. So you have to have, there's a difference between an optimal service and what the practical realities of what you have, the resources available to you. And it's always a compromise between the two. So there's a seemingly limitless demand for interventional procedures, and there's clearly not enough providers, okay? And to better address this, just think of the bigger river that you're swimming in and try and apply the best principles you can to your own practice so you don't become like this. Okay, thanks very much.
Thank you very much, Dr. Alim. Our next speaker is Major General Amjad Iqbal, a true pioneer in the interventional pain medicine in Pakistan with over 20 years of experience. He's a professor of anesthesia and a pain relief consultant General Amjad has served as the former head of Pain Medicine Center at CMS Rawalpindi and the Faculty of Pain Management at CPSP. He has established pain management clinics across major cities in Pakistan and is a pioneer of FCPS pain medicine program. In recognition of his outstanding contributions to healthcare, he has received Hilal-e Imtiaz in 2017. Sir, please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good afternoon, everyone. First of all, I'm thankful to the STSP chapter Lahore for giving me an invitation. I must also congratulate them for organizing such a beautiful event. It is nice to see that much of attendance even after the lunch in this session. Even in our anesthesia gathering, that much of a gathering is very rare. The topic I have selected for today's discussion is shoulder arm pain syndrome, a pain physician perspective. Shoulder arm pain is much more common than we think. After low back pain and osteoarthritis of the knee joint, this is the commonest pain problem which we see in our outpatient department. And unfortunately, with this problem, patient life is badly affected. He's or she is unable to perform the routine day-to-day activities. Patient can't put his hand in his pocket. He can't lift the thing from the side. He's unable to sleep at night. These are the things that makes his life very miserable. So this sort of a problem, it needs immediate attention. As I said, it's the third most commonest type of chronic pain we see in our outpatient department. Most of these patients are referred from other specialists. Patient already had physiotherapy session and are invariably on different type of pharmacotherapy. Some of these patients has already had some interventions. We all know that interventions are always very fascinating and at times very rewarding as well. But what we have learned over a period of time, that detailed evaluation and workup of patient must be done before undergoing any intervention, any sort of intervention. Shoulder and arm is a site of pain of so many pathologies from structure from and around this area. Pathologies from cervical spines are also not very uncommon cause of pain in the shoulder and the upper arm. Persistent pain in this area causes limitation of movement at shoulder and may badly affect the quality of life. Longer the duration of pain and limitation of movement is, it is more difficult to manage because of disuse atrophy of shoulder muscles and arthritic changes in the joint which occur with due course of time. Most of the time, more than one pathologies coexist and they should be addressed simultaneously to get desirable results. Its prevalence is around 20% to 30% of adults experience shoulder pain at some point in their life. Some studies indicate that the lifetime prevalence of shoulder pain can be as high as 70% in certain populations. It is more with the increasing age, more common after 50 years of age. Females are more vulnerable and more prone to get shoulder arm syndrome. Their occupational hazards are also there. Patients who are doing repetitive overhead movements like construction workers, painters, and certain sports, they are also at high risk. Sports like swimming, tennis, baseball, golfer, cricketers, weightlifters, they are more vulnerable to get shoulder arm pain. Somehow, most of the patients we receive in our clinic, about 40 to 50%, they also have diabetes as well. Exact cause, reason of association of diabetes with shoulder arm pain syndrome is unknown. Probably diabetes more common after the age of 50. Incidents are also more in patients with thyroid problems and with Parkinsonism. Before we do any intervention, or I jump to any sort of intervention for shoulder pain, a quick brief workup of the patient, that is must. History of the patient and clinical examination of the patient, that is very important. 90% of the patient can be diagnosed with a proper history and the clinical examination. If required, X-rays, MRI, NCS, ultrasound can also be used to confirm the diagnosis. In history, pain is the symptom. Now you see these diagrams. Pointer wala किधर गया? अच्छा, pointer wala गया. Sorry. You see these diagram. This is the site of location of so many pain problems. Problem from within the shoulders, problem from the back of the shoulder, problem from the upper back, problem from the neck present in this area. It is very difficult to diagnose the problem because of the location of the pain. Pain, it is not pinpointed. Most of the patients, they'll come to you, they'll be putting hand on their shoulder, and pain would be of diffuse type. Deep aches, diffuse pain, and you cannot pinpoint it. And this pain, it gets worse with lifting or rotating the arm, or with overhead activities. When lying, pain also aggravates when lying on the side of the bed, which often leads to disturbed sleep. As the condition gets worse, patient may experience pain even when resting the arm. At times, this pain gets worse with neck movement. Then there is a pain gets worse with neck movement, then cervical causes should be kept in mind. The next second symptom is the weakness and the decreased range of movements. Patients feel difficulty in lifting. Most of the patients, when they'll come, they will be lifting their hand with the other hand. They can't lift their hand upward. And with this, the range of movements is also decreased. At times, patients feel a funny sound. There's a crepitus, there's a clicking, cracking, grinding, popping noises while moving the arm due to the decreased stability of the shoulder. Now, this is problem. We can diagnose this problem from these symptoms, pain, weakness, and stability. We can at least have an idea from where the problem is arising. When this pain gets worse with overhead activities, the most probable causes are bicipital tendinitis, impingement syndrome, labrum tear, or rotator cuff tear. When pain worsens with neck movements, then it could be because of a cervical facial joint inflammation. When pain gets worse at night, it could be because of bicipital tendinitis, brachial neuritis, impingement syndrome, bursitis, and labrum tear. When there is a profound weakness in the arm along with weight, it could be because of a full thickness rotator cuff tear or nerve compression. If patient is unable to lift arm above shoulder height, it could be because of adhesive capsulitis or frozen shoulder. Sharp stabbing pain, it could be because of brachial neuritis, nerve compression, labrum tear. Catching pain with arm movements, it could be because of impingement syndrome, bursitis, labrum tear. Painful arc in the shoulder, that could be because of impingement syndrome or supraspinatus tendinitis. Noises with shoulder movements, it could be because of rotator cuff, labrum tears, and osteoarthritic changes. On physical examination, you can further pinpoint the diagnosis by doing the physical examination. On physical examination, rotation of movement in all planes should be carried out. In flexion, in extension, in adduction, in abduction, in external rotation and external rotation. This is a small diagnostic work chart. You can use this chart to pinpoint the cause of the pain at the shoulder before doing any intervention. If neck movements are painful around the joints, then it could be expanded examination of the neck, if it is positive. If there's no, then do the external rotation. If pain is more on external rotation, it could be because of a capsular problem. If there's a Painful arc. Painful arc means up to 60 degree of abduction and elevation, there is no pain. And if you raise it up to 120 degree, there is a pain. This we call it is a reflex arc. This is because of the impingement of the supraspinatus tendon because of the this subacromial bursa. So it could be because of the subacromial problems. If abduction or external rotation against resistance is weak but not painful, it could be because of a rotator cuff culture. Then frontal flexion, adduction and internal rotation is restricted. The problem is in the AC joint, acromioclavicular joint. If painful, where this scapular elevation is painful and restricted, then it is because of the sternoclavicular problem. Sudden onset of intense shoulder pain, physical examination nearly impossible. It could be because of the acute bursitis. After diagnosing, we can do intervention. The beautiful thing about this intervention at shoulders, because these interventions, they are very simple. They can be easily done in outpatient. Most of these interventions, they can be done in a sitting position. And with the landmark techniques, they can be done ultrasound, they can be done on a fluoroscope. But most of the time, we do these interventions because they are very simple, there are very less chances of any complication or any hassle, so we do with the landmark techniques. Of course, intervention because of the neck pain, that is the cervical medial branch block or cervical facial joint injection, they should be done under ultrasound guidance or under fluoroscopy. The subacromial injection, indication of subacromial injections, there are subacromial bursitis, rotator cuff injuries, shoulder impingement syndrome, adhesive capsulitis. These injections are very simple. The main landmark is the acromion. You can give from posteriorly, you can give from the lateral side, you can give from the interior side. But most of the time, we give these injections from the posterolateral margin of the acromion that is marked, and 2 centimeter inferior to that margin, needle is introduced towards and pointing towards the surface of the acromion, undersurface of the acromion. And this after 4 to 5 centimeter, the needle goes inside. We can inject the dye, inject the medicine. Most of the time, we give this combination of cortisone and local anesthetics. These procedures can be given under fluoroscopy as well. It can be given under ultrasound guided as well. If you have ultrasound facility available at your clinic, yes, it is better you give it under ultrasound. You see in the ultrasound guided picture, the needle is just over the supraspinatus muscle. Now, second intervention we do is the glenohumeral joint injection. Indication of these joints are these arthritic changes, it could be degenerative changes, or it could be inflammatory changes. Second indication is the bicep tendinitis, adhesive capsulitis, and labrum tear, they can be given. With landmark techniques approach, we can approach with the landmark techniques anteriorly as well as posteriorly. For posterior side, the site is the same as we give the subacromial injection. 2 centimeter inferior to the posterolateral side edge of the acromion, that is the entry point. While giving the injection, you can put your middle finger on the coracoid process and your thumb is at the 2 centimeter inferior to the acromion. So needle should be pointed towards the coracoid process. While entering the needle, if you come across, if you feel resistance because of the touching of the needle to the humeral head, withdraw needle for 1 to 2 millimeter, then inject the medicine. Anteriorly, it can be approached just lateral inferior to the coracoid process. It can also be given under fluoroscopy guidance. And if you have got the facility of this ultrasound, so it is better you give this injection under ultrasound as well. You see the needle. You see the needle in the, this is, no, this is this is a glenohumeral joint. You see the needle over here going into the glenohumeral joint. Acromioclavicular joint is a superficial joint located on the top of the shoulder joint. It is on the lateral margin of the clavicle, just under the skin on superior aspect of the shoulder. Indication: the arthritis, osteolysis, ligamentous injuries, acromioclavicular or cracoclavicular ligament injury. Needle, the superficial surface is felt and the injection can be given. It can be given under fluoroscopy as well as it can be given under ultrasound guidance. Suprascapular nerve block. Suprascapular nerve, it is a motor supply to the supraspinatus and the infraspinatus muscle and sensory supply to the glenohumeral and the AC joint. Its entrapment sites are the suprascapular notch and spinoglenoid notch. Indication of suprascapular nerve blocks are suprascapular nerve entrapment syndrome, rotator cuff injury, frozen shoulder, arthritic shoulder, or AC joint arthritis. Again, landmark technique can be used. During landmark techniques, the 4 points, the acromion, spine of the scapula, clavicle, and coracoid process are outlined. Then a line is drawn from the anterolateral edge of the acromion to the medial edge of the scapular spine. The insertion point for the needle is along this line. Usually this line passes from the lower edge of the, or the posterior edge of the acromioclavicular joint. From acromioclavicular joint, on this line 3 centimeter medially, that is the entry point of the needle. This needle, when it is entered, it should be inclined 30 degrees interiorly from perpendicular in the sagittal plane of the body towards the coracoid. This is a picture of fluoro-guided, and then this is a picture of this ultrasound-guided. This is the suprascapular spinatus muscle. This is suprascapular notch. So needle can be entered over here, and the injection can be given. Cervical facial joint and medial branch block. The indications are cervical facial joint syndrome or arthritic changes, cervical spine stenosis. These injections should always be given under fluoroscopy or under ultrasound guided. Now these are the picture. This picture, the first one showing the injection needle inside this cervical facial joint. That is the other one, that is the medial branch block. Can also be given under ultrasound. So this picture, this is cervical facet nerve, medial nerve, and this facial joint, this is the medial nerve. It can be given over there as well. Don't forget this picture. Can anybody guess what is this? Three to 4 patients during the last 10 to 15 years we have seen were referred to us for the management of shoulder pain. On examination of the patient were having macular-papular lesion of this area. That was the herpes zoster. Herpes zoster lesion also presented a pain in this area. And one of the patients, they had multiple sessions for physiotherapy for the management of his shoulder pain. On examination and exposure of the shoulder, it was found he was having macular-papular lesion and it was herpes zoster. So you must keep in mind that even herpes zoster can present as a shoulder arm pain. The interventional treatment of shoulder arm pain syndrome should always be combined with pharmacological support, rehabilitation, and lifestyle changes to get the long-term benefits from these interventions. Assessment of cervical spine should be an integral component of the shoulder arm pain syndrome. Thank you very much.
Thank you, sir. Our next speaker is Dr. Salman Ahmed Salim. Dr. Salman is a General Secretary of STSP and a focal person of pain medicine and CPSP. He is the Chief for Department of Pain Medicine and an Associate Professor in Shifa Hospital, Islamabad. Sir is the Supervisor and Examiner at CPSP and Rifah Hospital. Sir, please.
Assalamu alaikum. Thank you, organizers, for giving me this opportunity to speak on this topic. This long day going to be end. Probably this is my last presentation of the day. So managing abdominal pain after due to chronic pancreatitis is a difficult job for any pain specialist or anesthetist, because different patients behave differently with different treatment modalities. Today I'm going to talk on modality which is underused and understudied, that is splanchnic nerves, RFA, for the management of severe chronic pain of chronic pancreatitis. In my today's presentation, first we will briefly discuss the anatomy of the splanchnic nerves. Then we will compare celiac plexus neurolysis with splanchnic neurolysis and RFA. And then we will see the efficacy of splanchnic nerves, RFA, and briefly I will tell you the my technique of doing RFA in splanchnic nerves, and then we will I will share our experience, our department's experience with you, and our next planning of 1 or 2 years in this subject. The word splanchnic, it's difficult to spell and difficult to speak, but splanchnic nerve block, it's very easy to perform. People think that it may be difficult, but it's not difficult at all. Splanchnic nerves are arising from the spinal cord. It comes out from the anterolateral horn of the spinal cord and through the sympathetic chain, not relaying there, passing the sympathetic chain, and comes out from T5 to T12, go to the celiac plexus and forms the celiac plexus, where these nerves splice the upper abdominal viscera of the abdomen. These are all preganglionic fibers which relay in the celiac plexus, not in the sympathetic ganglions. Greater, lesser, and least splanchnic nerves are the main supply of the celiac plexus. These nerves are bounded in a narrow space when coming from the thorax to the abdomen, and in between the vertebral body and the pleura. All these things are pleura, and these nerves are placed laterally along the body of the vertebrae. The volume of this compartment is approximately 10 ml, and if we give local anesthetic or alcohol, we can give up to 10 ml, which can cause neurolysis. Now we will see the outcome of celiac plexus in different studies done between 1999 and the later years. In these studies, we see that there are variable results of celiac plexus neurolysis, and the pain relief was approximately between 25 to 80%. If we see the mean pain relief, it seems that about 60% of the relief occurred with celiac plexus neurolysis, and 40% patients even suffer after this block and pain doesn't become less. Although there are very few studies found in the literature regarding splanchnic nerve block and neurolysis, and even less studies are present for RFA ablation. However, we see a case series of 18 patients published in Saudi Journal of Anesthesiology very recently in 2024, and they said that there is significant pain relief for up to 3 months in patients of chronic pancreatitis. There is another observational study done in 2017, and they found that there is a reduction in pain severity with splanchnic nerves, more pain reduction with splanchnic nerve block as compared to celiac plexus block. Regarding splanchnic nerve RFA, we see a case report published in 2017, and it is said that verbal numeric rating scale reduced to 0 by 10 after this procedure, and it remained 2 by 10 even after 1 year. In Australian New Zealand journal, we found another case series of 8 patients in 2005, and pre and post procedure, we see there is lot of difference in pain relief, and even moods, quality of life, quality of relationship, and activity score improved after the RFA procedure. You can see here before and after the procedure, the difference in worst pain and the difference in best pain and the mean pain, which improved. Even anxiety scores improved after the RFA block procedure. Now, a few words about the technique. We routinely approach to the patient in prone position. Patient lies in prone position, and T11 vertebra is targeted and identified. And in obese patient, we use 150 millimeter 20 gauge RF needle, and in thin and lean patient, we can use 10 centimeter needle. We insert needle below the costochondral joint on the lateral side of the vertebra, and we go along the lateral wall of the vertebra. The needle position is confirmed on lateral position, and with the injection of dye, we can see the exact position of the needle. We pass 2 needles bilaterally and do the RFA, and we place our final needle point is on the junction of middle third and the anterior third. After the procedure, we observe patient closely for 4 to 6 hours. Then we discharge by giving a few instructions to the patients. What is our experience in last 6 months, which we have done in last 1 year? And we find that after bilateral splanchnic nerve RFA in patients of chronic pancreatitis, the pain relief after 3 months was significantly good, and pain came to up to 2 by 10, and patients' opioid consumption was reduced in almost all of the patients, and in many patients, and afterwards they stopped taking opioids. all patients resumed their jobs and other activities of routine life, and we are planning to observe all the patients for minimum 1 year, and we will then publish a case series for this procedure and these patients. Our next plan in this regard is a randomized controlled trial in patients with chronic pancreatitis having severe abdominal pain, which is refractory to the routine analgesics. We will compare splanchnic nerve RFA with celiac plexus neurolysis, and pre and post procedure we will compare the quality of life, perceived stress scale, visual analog scale, and analgesia consumption after the block in both groups. We will observe the patients after the block for 1 year, and after 1 year we will make opinion which one is better. Going to end in summary, we can say that splanchnic nerve block or RFA treatment is comparable with celiac plexus neurolysis for pain control in patients with abdominal cancer and in patients with chronic pancreatitis. It is associated with a significant reduction in analgesic consumption 2 months post procedures, and splanchnic nerve RFA appears to be an effective and safe alternative to celiac plexus neurolysis, independent of distorted anatomy of the celiac plexus, and has fewer adverse effects and a longer survival rate. Thank you.
Thank you very much, sir. It was a very informative session. Now I would like to proceed towards the question and answer session. Respected chairs, sir, any question from your side, from our speakers?
We should open the floor for the audience.
Audience as well. I was proceeding for first towards you, and then I will proceed for the audience as well. Any question from the audience side? Ji, Dr. Usman.
Just a question to Ellen regarding your advanced prioritization. When you're setting up that service, did you face any resistance or challenges from the primary care, especially for the referrals which you were rejecting, and how easy it was to, like, just from the triage of the referrals to bounce the case back to the GP, just getting your insights for that?
Those that were referred back to the GP were given medication advice, or they felt that it didn't require tertiary service. Not all chronic spinal pain or chronic back pain, for example, needs to be seen in a hospital setting. A lot of it can be managed in primary practice. So we offered advice. Some of those discharges back to the GP were for insufficient information, inadequate referrals. Some referrals we get, you wouldn't believe the quality of the referrals. I've had, "has pain, please fix," all in capital letters, and as a referral. You cannot triage that. That has to go back to the GP. You can't change referral practice without discharging either. No, but we didn't face any significant... I did have a concern about bringing patients direct to procedures without being examined. So that was a concern of mine in the beginning. But actually, if you are careful about your selection, if the patient's been seen by a specialist physiotherapist, for example, and has a comprehensive examination already, or has been seen by a good GP and has an exam, you can bring them direct for intervention with the proviso that I examine and document an examination as I'm consenting them and keep that in the chart. That was my main concern, not discharging back to referrals. You're entitled to just, if you don't have an adequate referral, you're entitled to not administer it. I mean, you would never send a patient to a cardiologist with a letter, "has pain, has a heart, please fix." That's just not a thing that a cardiologist would accept, and I don't see why we would either. Yeah.
Any other questions?
Thank you, Dr. Allen.
That's
Okay, Dr. Kenny.
आपकी इजाज़त से.
Yes.
Just a comment about Dr. Mohjir's presentation about the migraine pain. I think the migraine pain is, in our setting, at least in our setup, they are most of the time misdiagnosed. So diagnosis is actually the main issue. Then the people come to us, they have been labeled as migraine pain for many months to many years. And then when we go to the history and physical examinations and try to review the whole concept, so most of the time, most of the patients who come to me, at least to my clinic, they are actually occipital neuralgia. So occipital neuralgia is most of the time mislabeled as migraine, as a unilateral occipital neuralgia becomes any pain which is आधे सर का दर्द है, which is unilateral pain, तो उसको आराम से जीपी भी करता है और even sometimes the consultants जो हैं वो भी उसको कि जी migraine ही होगा क्या, ठीक है, तो इसलिए उसका diagnosis important है. मैं तो मेरे तो most of my patients they get relieved by a probably placed once or twice as a occipital nerve blocks.
Actually, I have a question for Mohjir as well. Two questions really. One is Botox is quite expensive. Is that a limitation that you would have? Like I have problems prescribing it sometimes in terms of cost. Is that a limitation for its widespread use in Pakistan, for example? And second question is, when the headache becomes episodic rather than chronic with more than 15 episodes a month, how do you titrate them down? Do you extend duration of procedures from 3 months to 6 months perhaps? And do you see any difficulty? Because I have a collection of young patients who I cannot reduce the frequency of the injection below 3 months, or they get upset. And I'm looking at them thinking, I'm going to be doing this for the next 30 years, the patient's in their early 20s. How do you manage that?
So actually, I'll address Brigadier Kiani's point first of all with regards to misdiagnosis. You're absolutely right. I mean, the misdiagnosis, it ties into what General Amjad was saying about neck, shoulder, head syndrome even, because radiation, for example, for cervical facet joints can present with headache. And therefore, we've been very clear. The patients that we're getting into our clinic have been diagnosed as suffering with chronic migraine by a neurologist, not by a physician, not by a general practitioner, not by a rheumatologist. It is a true diagnosis of chronic migraine. And they've already tried 3 prophylactic agents for migraine before they step through the threshold. So the diagnosis is pretty robust by the time that they come and see us. So I hope that addresses that question. But you're right, the greater occipital neuralgia can present with a similar presentation. And of course, the greater occipital nerve block is like, I regard the greater occipital nerve block like a shotgun in the world of headache pain management, because you can use it for migraine, you can use it for greater occipital neuralgia pain, you can use it for post-dural puncture headache pain. So it is a catch-all, and of course, as I've said, some of our patients will go on to have greater occipital nerve blocks. To address your question, I don't know how much Botox costs in Pakistan and how available it is. I don't know whether the...
Alan's question was part of my second part of my question. I also wanted to comment on this because dogs here in Pakistan is quite expensive.
Yeah.
So if we have to give 31 injections in one session,
Yeah.
31 means say
155, sorry? 155 units. So Botox comes in 50, 100, and 200 unit vials. Unit vials. So I use 200 unit vial because I'm giving 155. With the preempt protocol way of giving it, you can give up to 195 units. And it's what's called follow the pain. So if they have slightly more temporalis pain, you can add in a couple more injections there. But it's the 200 vial. In England, it costs about £160 for that one vial. Plus, of course, you've got your consumables. No, it's 1 vial. 1 vial of 200. Yeah, correct. Yeah, and that would be every 3 months. Yeah, so that would be every 3 months. So you have... Yeah. 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 So you have to balance that with the burden of the disease, the burden, economic burden to society, which I touched on. So 95 billion pounds pan-Europe is how much it costs through them not being able to work, them not being able to pay taxes. Also, the cost of what the prophylactics cost. So otherwise it'd be on topiramate or candesartan or a beta blocker. But yes, it is expensive. So when I instituted it in my practice, we had to limit how many for the first 2 years we would be putting down that pathway. So it was limited to 10 in the first couple of years, and then they looked at the numbers. So that's why I presented our numbers. So you get an idea of, out of the whole 250 referrals per month for all pain procedures, and in 24 months, we only had 41 patients that were eligible for the Botox. So you're looking at very small numbers because you've got to have a diagnosis of chronic migraine made by a neurologist, and they fail 3 other treatments. So the numbers are quite small. In terms of your other, the other question about them being resistant. So as I was saying, we have patients that come every 3 months. I've been doing this now for about 10, 11 years. So I have patients that are now on their 35th round of the Botox. And so there are patients that tell you that come a week or 2 before the 3-month follow-up, the headache frequency has gone up. That has to be documented. So if they don't bring their diary, they don't get the injections, because we have to be able to justify that we're doing it as per the preempt protocol guidance. However, if a patient comes back and they've become episodic, we say to the patient, we will not inject you on this occasion because you don't meet threshold. Yes, you're still getting your migraine headaches, but by giving you Botox at this stage, it is not going to reduce it any further. Number 1. Number 2, every time you give Botox, there is a risk that initially you'll get a flare-up of their pain. Who wants to have 31 injections in the head without any significant guarantee that it's going to help? And then, of course, the third point is that some of these patients will come back after a few months and they're still episodic. And then they will go another few months. So as I said, I've got a handful of patients that have gone 1 year without needing Botox. They've come back and then they've become chronic again, and then they've come back every 3 months and so on and so forth. I hope that answers your question.
Dr. Amjad, you want to ask something?
Any final comments from the audience?
I have single question. It is in fact from Dr. Mohjir. And sir, this question is slightly away from your topic. I am going to ask regarding very practical thing. We have experienced encountered number of patients in our OPD that was diagnosed from a number of places to be migraine, and on detailed history examination, it doesn't comes out to be migraine. And patients have used multiple medications and they have entered into the phase of multiple use headaches as well. Sir, how to prevent this thing? What is your opinion in this case? Because 2 of my colleagues have also undergone the same scenario. They were diagnosed by some pain physician as migraine, but it was not that. And later on, one of my colleague also has diagnosed intracranial causes as well for that headache. So what's your opinion? How can we save our resources? And how can we manage such conditions? How can we prevent drug overuse headaches? So it's slightly away from your topic, but
no, I mean, it's exactly what Brigadier Kiani was also alluding to. Chronic overuse headache, analgesic headache, even with paracetamol, is very, very common. And so one thing that happens is when the patients go through the neurologist, the first thing the neurologist does is stop any analgesic that they're on. So if they're on paracetamol, because often you'll find these people will be munching cocodamol, codeine, ibuprofen, all the time because they don't have anything else that they can use for the headache. But that then causes analgesic overuse headache, which is not migraine, obviously. So when they go and see the neurologist, not a pain doctor who's making the diagnosis, not a primary care physician, not a rheumatologist, it is a neurologist that is making the diagnosis, who, if appropriate, would have investigated them with a head MRI scan or other investigation. You know, they may do opening pressures with a lumbar puncture, they've excluded any other diagnosis and have come to the conclusion there is the IHCD-3 classification for making a diagnosis, which is what our neurologists are following. So the diagnosis, by the time they come to us, has been made. But clearly in your example, in your case, that is not what's happening. The diagnosis appears to not be made by someone that knows how to make a diagnosis. You know, there are certain criteria that have to be met to make a diagnosis of migraine. You know, are they having an aura, for example? Are there certain triggers like chocolate, cheese? In the UK, it's wine is a common thing, etc., etc., etc. It's not just a unilateral severe headache. That does not make a diagnosis of migraine. So I think it comes back to what Brigadier Kiani was saying. You need to have a robust mechanism for the diagnosis to be made.
Sir, very rightly said. I think there should be integrated approach among different departments so that a collaborative approach makes the diagnosis better for the patient.
Okay, I have a question from General Amjad. Sir, regarding shoulder pain, actually most of the time we also face with such a patients who are coming after breast surgery, especially MRM. And those patients also have like a frozen shoulder. They have a pain there and their movements also very limited. So what is your experience according to this, and what is the management? Whether we should go and advise them for the physical therapy or interventional therapy is effective for them?
Most probable cause in this scenario, it would be because of the muscle or nerve damage in that area. So local blocks, petrolus nerve block, that is another option. Or on examination, you can find what is the exact generator of the pain, as you can address that. And at the same time, I will share my own experience as well. Patient undergoing this surgery or this radiation therapy after breast surgery, it is very common to have this facial joint inflammations as well. So facial joint should be taken into consideration, and facial joint nerve block, it could help them.
Okay, thank you.
I have a question for Dr. Salman. While you're doing a spinal nerve radiofrequency, did you injected local anesthetics with the steroids after the procedures or not?
First, we give diagnostic block. If it works, then we give radiofrequency ablation.
My question was, after doing radiofrequency, many people, they inject local anesthetics after the procedures along with some steroids, without even steroids. Did you do that in your procedures?
To prevent neuritis, you can give some steroid in there. And some people also give alcohol in that space. You can also give alcohol, it will come down and go to celiac plexus. You can also put some alcohol there. There are some studies, they routinely do radiofrequency ablation, and then after the ablation, they give 10 ml alcohol on each side.
Thank you.
Any more questions? Ji sir, please.
Okay.
My question is from General Amjad. What are the role of PRP or the prolotherapy in shoulder pain syndromes? And what is the referral, when we refer a shoulder pain syndrome to some arthroscopic surgery, when we can refer this patient?
I do not have any idea of giving this PRP in this shoulder joint, but the injections of hyaluronic acid intraarticularly in the shoulder joints, it can help, especially in cases where there is osteoarthritic changes or there is a degenerative changes inside the shoulder joint. Yes, of course, when this hyaluronic acid injection, they are not responding, steroid injection, they are not responding, we can always send these patients to the orthopedic surgeon for arthroscopic examination and treatment or management whatsoever he like.
Dr. Mohjir, please hand over to Dr.
Is it working? Can you hear me? Yeah, just to give a small perspective about this, just be very curious, how many people are actually doing PRP here in Pakistan? Is it a big thing, or have people decided it doesn't work? Just out of interest. Does anyone do PRP? You're doing PRP? Yeah. So it's interesting because in the UK, in fact worldwide, within the interventional pain management practice, PRP is going crazy. Every Tom, Dick, and Harry is doing PRP. The problem with it is the evidence base at the moment is not very strong. The area where I think it has the strongest evidence in the shoulder, whatever joint, is for tendinitis. That is where, but people, like what happened with pulsed radiofrequency, people are starting doing PRP injections everywhere. Spine, facet, knee joint, the whole works. And one has to be careful. The practice has to be evidence-based. And therefore, really, the evidence at the moment, I think, is in its embryonic stage. I think it will come, but at the moment, I think it has its niche area where it's good for tendinitis pain, but for general joint pain, I don't think the evidence exists. The other thing was just an observation of mine in my practice for doing radiofrequency denervation, was this issue of injecting steroids afterwards. So there's two things. The first thing is, should you inject steroids before you do the radiofrequency denervation? So injection, typically what people used to do is inject local anesthetic, put the needle in, they inject local anesthesia and steroid, and then they do the thermal lesioning. So there was a large study by Manchakanti that showed actually lesion size is reduced if you inject local anesthesia and steroid before you do the thermal lesioning. The other thing is to put steroids in afterwards, and you're absolutely right. So I put steroids in afterwards for the neuritis. But interestingly, during COVID, of course, we were all worried about steroids and the risk of getting infection. So I stopped putting steroids in afterwards to see whether it make any difference to the incidence of neuritis. Now, in the 6 months that I didn't put steroid in, there was no difference. Interestingly, it didn't make any difference. I put local in afterwards, but no steroid. So I wonder whether we don't need to use steroids, and maybe we over-worry about neuritis being a complication, but in practice it might not be. But I don't have any firm evidence base for that. It's just anecdotal.
I would like to thank all the speakers for their valuable insights and sharing experience. Is there a question? Okay.
I can.
So,
can I ask few words about PRP in shoulder? Can I ask few words about PRP in shoulder joint?
Sure, please.
Ji sir, please.
Okay. We use PRP in shoulder joint where we find partial tear of the supraspinatus muscle or tendon, where it works good. Yes. Outside the joint, along the muscle, sometimes inside the muscle.
So we declare the session closed with this.
Please.
So before
you just enjoy your chair for two more minutes. So again, comment on Dr. Mohjir's comment about evidence-based medicine. So you are strictly telling us not to do the PRP unless there is any evidence. So how can there be an evidence if we don't do anything? If we don't do a procedure and don't publish it, anyone who publishes, he has to do it in the first place. So somebody who's doing it under certain presumption, under certain that this thing is going to work. So we presume that there is a logic behind this thing to work, and then we do it, and then we publish it. So if we stop doing anything, or if we something which is safe, which is not otherwise causing any harm, it may not be very useful. But once we do it, then we will come to know that whether it's useful or not. So who should do it, who should not do it? And who should wait for the evidence? Who will generate the evidence?
That's a very, very valid point. So what I would say is those that are doing it have a duty to publish their results.
Yes.
That is their duty. That is their responsibility. Yes. So if they are saying, I'm getting very, very good results, that's fantastic news. Yes. Because shoulder pain is a very difficult pain to treat, as you and I all know. If you are getting fantastic results, please do not keep them to yourselves. Please publish. Robust evidence is what is required for all our interventions, and specifically for the newer interventions. So please be grateful if you could collect your case series and publish them so that we can all then look at the results.
And such research is not only to prove something. Sometimes even we do the research to disprove something. So you have to do this research.
Can I just add briefly? Sorry, just it's evidence-based is obviously what we practice, but the original definition of evidence-based medicine has three parts. One is it's not alone the clinical evidence, it's the professional's experience and the patient's values. So as I mentioned briefly, I looked for evidence that I would be 100% on every decision I make. It doesn't exist for pain medicine. And you have to accept that your professional experience will influence some of the treatments that you give. So for example, PRP, the evidence is poor, but I will still give it to some patients where they're allergic to steroids, for example, and I don't have anything else to offer, with the principle of first do no harm in mind. But we have to bear in mind evidence base has three principles, not just an automaton response to scientific rationale. Thanks very much.
Thank you again for your provoking, not only talks, but also question answers. So with this, we declare this session closed.
Thank you so much, Dr. Amjad, Dr. Liaquat, and all my distinguished speakers for their precious time. And tomorrow there will be session 5, chronic musculoskeletal pain, and after that prize distribution session for the poster competition and fee paper there will be. Thank you everyone, and please join us tomorrow as well.